Dad?
Good afternoon. It's my great pleasure to introduce Arun Mohan from the Division of Hospital Medicine. Arun is the Vice Chair for Information Technology for the Department of Medicine. He's also the Medical Director of Care Coordination here at Emory University Hospital. He has both his MD and MBA degrees from Emory. He has active ongoing program of active research in health disparities and is currently the PI for an AHRQ grant to look at the development and pilot testing of a decision aid for prostate cancer. I'm very pleased to have him come and talk today about interventions to reduce length of stay among hospitalized patients. Arun?
All right, well, good afternoon, everyone. It's nice to see some friendly faces in the audience. Hopefully there are no tomatoes that you've packed away. But it's really a pleasure and an honor to speak with you here today. As some of you know, I took over the role of Medical Director of Care Coordination a little more than a year ago. And on its bad days, I feel a little bit like the hospital's bouncer-in-chief. But on its good days, I really have an opportunity to think about quality and efficiency and what we can do to improve them. So Emory, as most of you know, is a pretty busy place. Last year, we saw 3,500 admissions. Our daily occupancy rate is well over 90%. 11% of the time we were actually on medical surgical diversion as a result of lack of beds. And roughly 300 patients last year were accepted through our transfer service, but because of lack of bed availability, could never arrive. And so given that the supply of beds in our hospital, at least until the bed tower is completed, is relatively constrained, the question is what can we do to actually improve the efficiency of care we deliver without compromising or perhaps even by increasing the quality of care? And that's what I want to talk to you about today. So here's a roadmap for our conversation. We'll start by reviewing the importance of hospital length of stay from both a quality and financial perspective. We'll describe some of the national trends around length of stay. We'll explain the key drivers around length of stay, specifically what drives variation, both at the national level and regional level. We'll talk a little bit about how Emory is doing, both Emory University Hospital as well as Emory Midtown. And then we'll spend most of the conversation talking about a systematic review I'm doing with some of my colleagues here, including Dr. Dressler here in the audience, describing healthcare delivery interventions to reduce length of stay. So first, let's start with a case. This is Miss Jones. Miss Jones is probably very familiar to many of you. She's 55, has a history of heart disease, with systolic dysfunction, comes in with decompensated heart failure. And she's admitted at 9 p.m. on September 1st and discharged at 1 p.m. on September 4th. So the question is, what is her length of stay? Is it A, 2.66 days, B, 3 days, C, 4 days, or D, A and B? So everyone in favor of A, raise your hand. B, a couple of hands. C, and D. And for the people who asked to answer D, I want to ask you how you could possibly have a length of stay that is both 2.66 days and 3 days. But it turns out that's actually the correct answer. It's actually D. And so the important thing to remember about length of stay is that it is measured very differently depending on where you are, and it's important to ask exactly what's being measured. And so at the patient level, it can be measured in two ways. One is simply the time of discharge minus the time of admission. So you can imagine this gives us fractions of days, hours. It's also measured as the number of midnights that the patient occupies the bed, and that's generally due to technical limitations for some of our systems. And so here at Emory University Hospital, for example, our census is measured every night at midnight, and so if you're discharged on day 3, but you're not there until midnight, that doesn't necessarily count towards your length of stay. At the hospital level, it's measured in a couple of different ways as well. First is something called length of stay index. That's simply the observed length of stay, the actual length of stay, over the expected, so you can imagine that's a ratio. The second is the mean adjusted length of stay, so you're adjusting length of stay for some demographic and clinical factors. And the third is average length of stay, which is the total number of discharge days divided by the total number of discharges. So why do we care about length of stay? It's, as many of you know, that hospitals are generally considered places of healing, but you also know that hospitals can be places where adverse events can occur. So this is a study from 1964 from someone named Eric Schimmel. And Dr. Schimmel was a physician at Yale New Haven Hospital, and he was interested in the prevalence of adverse events in his population of patients. So he did a chart review of 1,000 consecutive patients admitted to Yale, and what he found was that about 20% of the patients admitted had experienced some sort of adverse event during their hospitalization, and that of that 20%, roughly 8% actually died. Now the question is, how are we doing now? Better or worse? Who thinks better? Worse? The same? A lot of hands. And that's about right. It's about the same. So here's a report from OIG looking at Medicare beneficiaries just last year, and they show that 1 in 7, or they estimate that 1 in 7 Medicare beneficiaries experiences some adverse event. An additional 13.5% had some adverse event causing temporary harm. And so we're talking about roughly 20-something% of patients who experience an adverse event here in the hospital. Now, although longer lengths of stay can contribute to complications, we generally think that the mechanism is reversed. In other words, complications lead to longer lengths of stay. So here's some results from a Danish study that demonstrates this association among stroke patients. And so they used the National Danish Registry, and they looked at patients admitted with stroke, and they looked at whether or not the presence of various complications, things like pneumonia, UTI, VTE, how those affected length of stay. And you can see that the adjusted ratio here, if you have a UTI for a fall after a stroke, for example, is about 3. So in other words, your length of stay is 3 times as long as someone who doesn't have a fall after a stroke. Similarly, for UTI, for pneumonia, you're talking about lengths of stay that are doubled if you experience those complications. And so you can begin to see why length of stay is considered a quality indicator, because in these cases, longer lengths of stay may reflect some sort of complication. And the other reason length of stay is important is simply profitability. So currently, most of our hospital stays are paid on a DRG basis. So that is, a patient comes in the hospital, they're assigned some sort of principal diagnosis, and on the basis of that diagnosis, the hospital is given a lump sum payment. So I want to walk you through a couple of scenarios that helps you understand exactly how these things influence profitability. So in scenario 1, the patient, let's say, is admitted with pneumonia, is reimbursed. We're reimbursed $10,000 for the admission. It costs $1,000 a day to care for the patient. Let's assume that the patient stays 20 days. In that case, the hospital actually loses $10,000. Scenario 2 is that the patient stays for 5 days. So you can see the cost here for caring for that patient for those 5 days, $5,000. But then the person's discharged, the bed is empty. You can imagine there are some costs associated with paying for that bed, even though no one's in it. But still, the hospital will come out on top. In scenario number 3, you have a patient who's discharged in 5 days. That bed is immediately turned over. Another person comes into the bed with the exact same diagnosis, exact same length of stay, and you can see the hospital walks away with $10,000 in profit. So here is a look at what it costs to actually care for some of our patients here at EUH and at Midtown. And there are 2 ways of thinking about costs. One is a fixed cost, and these are costs that generally don't change over time or change very little. And then variable costs. The variable costs change depending on volume. In other words, if you don't do something, you don't spend the money. So examples of fixed costs are things like the hospital, the building itself. Examples of variable costs are things like medications or supplies. And so you can see here the total cost per day, and this is both for ICU and non-ICU patients across services, is slightly higher at EUH than Midtown, and this reflects some of the kinds of patients we see, the difference in the case mix, the product lines. And you can see that the difference, for hospital medicine, for example, is it's not that high. For cardiology, where you have a much higher complexity of patients here than at Midtown, you can see that difference is substantially more. And if you look at variable cost, those numbers sort of hold true. And so the question here is, if you're a hospitalist and you discharge someone at Emory a day sooner, do you actually save $1,320 in costs? And the answer is not quite. And the reason is because not all days are equal. And so this is a study from Paul Taheri, and Paul is a trauma surgeon at Yale, and they looked at variable costs according to the day of hospitalization. So you can see here early on in the hospitalization, a lot of these costs are front-loaded. Early on, the costs are really high. Over time, those costs decrease. So in the day of discharge, the actual cost of caring for a patient are roughly $500, which is not to say that $500 isn't important, that there aren't other reasons to improve efficiency, but that's what we're talking about. We're talking about at least $500 a day in caring for our patients. So next, let's talk about national trends in length of stay. So what we've seen over the last 2 decades is a pretty substantial reduction in length of stay. So this is data for the American Hospital Association looking at length of stay among hospitalized patients in community-based hospitals. And you can see that in 1991, the average length of stay was 7.2 days, and that since then we've seen a roughly 30% decline to 5.4 days. You can see that among heart failure patients as well. So this is a study from Hector Bueno and Harlan Krumholtz, and they're looking at length of stay among heart failure patients. As you can see, back in 1993, the length of stay for a heart failure admission was roughly 9 days. By 2006, you're down to a little bit more than 6 days. So substantial reductions over that period of time. And this is true as you look at any number of conditions, this is the case. I think Manj Okadar at last week's Grand Rounds talked about the length of stay for a patient admitted with AMI. In fact, Lyndon B. Johnson, FDR at Emory back in the 1940s. I mean, the length of stay was weeks. And so we see over that period of time a substantial compression in length of stay. So one of the questions you may be asking is, as we're reducing length of stay, does that somehow negatively affect quality? And so I think it's tempting to believe that as you reduce length of stay, you might also be increasing readmissions. And so this is a question that has been looked at by a number of investigators with essentially the same result. So here is a study, this is the results from a study by Peter Caboli that was recently published in Annals. And Peter is a hospitalist at the Iowa City VA. And he looked at VA discharge data, the entire VA, for nearly 10 years. So we're talking about roughly 4 million admissions. And you can see that over the study period, there's a nice reduction in length of stay, sort of roughly 25% reduction in length of stay. But you can also see a comparable reduction in readmissions, and essentially very little correlation between these two. Now, when they put this into multivariate analysis, they did see a very, very slight relationship between low length of stay and readmissions and long length of stay and readmissions. So you can almost imagine kind of a U-shaped curve in theory, where on one end, you don't do anything for the person, and the patient is discharged, they come right back. On the other end, it doesn't matter what you do, because they are so sick, they are going to be readmitted. Now, I think the good news is that we're probably, that bottom part of the curve is probably pretty wide. And everything that I've seen suggests that regardless of reductions in length of stay, we're unlikely to see reductions or changes in quality. So what are the key drivers here? So let's talk about Miss Jones again. So Miss Jones comes back to the ER with chest pain. This time, it looks like she's having an NSTEMI. So she started on heparin, she undergoes a catheterization, demonstrates a lesion. So what is the difference in length of stay we might expect if Miss Jones is admitted to a high-performing part of the country versus a low-performing part of the country? Is it A, 0.5 days, B, 1 day, C, 1.5 days, and D, 2 days? And the answer is 1.5 days. And so what we're seeing is that despite decreasing length of stay, we're still seeing a fair amount of geographic variation. So depending on where you're admitted, you are spending more or less time in the hospital. So this is a map showing median length of stay by hospital referral region for patients admitted with AMI. These are Medicare beneficiaries. And you can see that in each HRR, hospital referral region, simply reflects a market for regional healthcare delivery. So hospital referral regions with lengths of stay that are significantly lower than the national median are primarily over in the west, kind of the north central, and in the east and the south central, you're seeing much higher lengths of stay. So the difference between 4.98 days and 3.6 days. And this is true not just for AMI, but for heart failure, for pneumonia, and you see some of this variation internationally as well. So this is data from OECD looking at average length of stay depending on the country you're in. So you can see, the red arrow there is the United States. The average length of stay is about 4.9 days. But if you are in Japan or Korea, you can see substantially longer lengths of stay. So there's a lot of variation in terms of how much time people spend in the hospital. And if we go back to AMI, you can see that here again. So if you're in Korea, the average length of stay for an AMI patient is probably closer to what it was for FDR. It's 13.7 days. If you're in Denmark or Sweden, the average length of stay is 4 days. And if you actually look at outcomes in these countries, it turns out they're actually relatively comparable, surprisingly. So what is driving this variation in length of stay? So one group that tried to answer this question is based at UT Galveston. And what they did was they used 100% Medicare data for the state of Texas. And they looked at about 1,100 hospitalists and practicing in about 268 hospitals. And they used multi-level models to answer the question, what portion of this variation was due to the hospitalist or physician, what portion is due to the hospital, what portion is due to the patient, and what portion is unexplained. And what they found was that about 2.6% of the variation was attributable to the hospital, 2.94% is attributable to the hospitalist or the physician, 11.64% is attributable to the patient, and the vast majority is sort of unexplained. We don't know. So, what are the things that explain this at each of the levels? So at the hospital level, we're talking about things like staffing. We have good evidence now that staffing ratios, specifically RN staffing ratios, are directly correlated with length of stay. So the more nurses you have, the better you do. There's a growing body of evidence that suggests that physician workload is also related to length of stay, which hasn't been something that we've talked about, I think, as a community for some time. I think it goes without saying that care coordination and availability of a care continuum are important. So if you have nowhere to discharge a patient, they're going to reside in the hospital. Models of care, quality improvement infrastructure. There's some nice papers looking at what happens to hospitals who participate in Get With the Guidelines or quality improvement programs. It turns out those hospitals have a shorter length of stay. And certainly models of reimbursement and the ability to operate 24/7. And we'll talk about the reimbursement in just a moment. In terms of the physician, we're talking about things like experience and specialization. These are especially true among surgical specialties and procedural specialties. Culture plays a big role, so just what the expectation is in the community. Fragmentation of care, which we'll talk more about. And again, reimbursement, that's a theme, by the way. Reimbursement makes a big difference. Third is at the patient level, and these are things that you might expect. Medical reasons primarily, so clinical differences, social differences, cultural, financial. So this is an interesting study that was published recently in the Journal of Hospital Medicine. And they were interested in to what extent fragmentation of care actually increases length of stay. And so what they did was took 1,100 patients who were in community-based settings, who were admitted with either heart failure or pneumonia. And they computed something called a fragmentation of care index. And that's essentially the amount of time that's not delivered by the primary hospitalists. So the higher the fragmentation of care index, the more fragmentation there is. And they found that the fragmentation of care index for pneumonia was 22%, and for heart failure, it's 18%. And when they put this into multivariate models, they found that for every 10% increase in fragmentation index, you have a change in length of stay of 0.3 days and for heart failure and 0.39 days for pneumonia. So again, the longer, the more handoffs we're making, potentially there's some implications here for efficiency. Here is some data looking at Medicare financing. And so, the question here is going to be, what happened in 1984 that caused a substantial decline in length of stay among Medicare beneficiaries? And so for those of you who were practicing then, you'll know that, from 1967 to 1984, Medicare was paying doctors and hospitals on the basis of cost. So, literally, the hospitals submit a cost report. The Medicare would look at it. They would say, these are the costs that are allowable, and they would send the hospital back a check. Certainly did not create an incentive potentially to improve efficiency. And so in 1984, they made the transition from that to this DRG-based system. And you can see if you look at length of stay among medical, surgical, psychiatric diagnoses, relatively stable for some period there between 1981 and 1983. And then almost immediately, beginning in 1984, you can see a reduction in length of stay. So this is an example of how financing drives physician and hospital behavior. And the other factor, I think, affecting variation is barriers to discharge. So this is a study from 1989 from Boston Medical Center. And the results are probably not that different from what we would see today. And so essentially what they had was they had a research assistant who followed two services around. He followed the GI service, which is primarily the surgical service, and the gen med service. And they were looking at non-clinical barriers to discharge. And every time there was a non-clinical barrier to discharge, sort of put a checkbox in a certain column. And what they found was that most barriers to discharge had to do with facility and bed unavailability. Second on the list was availability of surgeries and procedures. And third on the list had to do with differences in physician comfort with certain things. And I think what's interesting to note here is that patient factors are actually quite low. So oftentimes you talk to docs, they'll say, well, my patient really didn't want to leave the hospital, that's why I kept them here. And certainly that happens, but it probably happens less of the time than we can remember. So how are we doing on length of stay? So it's important to know that Emory uses data from something called the University Health Consortium. And the University Health Consortium is a consortium of about, I think it's 300 hospitals around the country. These are large academic medical centers, places like the Mass General or the Mayo. And what UHC does is takes our discharge data for inpatients, so not people who are admitted as observation. They risk adjust those, the level of the DRG, and they share that data publicly. And so the data is attributed to the discharging physician, and it's, again, this is based on billing data, or who is reported to do the discharge summary. And we exclude outliers. So patients with length of stay that are more than 3 standard deviations above the mean are excluded from this calculation. So last year that was about 3% for us. And you can see here, again, this is the length of stay index. So 1 is where we want to be, so that's actual over expected. And you can see that across Emory Healthcare, which is the line in the blue, we're doing better than expected. And the trend has been a little bit downward over the course of the year. At EUH, again, Midtown, UWash, which has us down to kind of finely tuned science, everyone is doing well from a length of stay index perspective. But when you take a little bit closer look, you'll see there's a fair amount of variability at both the unit level. So you can see here there's some units where, and this is units within Emory University Hospital, some units where the length of stay is index is 1.25, and other units where it's much lower, closer to 1.6. And if you look at this at the physician level, you'll also see pretty substantial variation. So some doctors have a length of stay index of more than 1.5, others much lower than that. Some of this is due to variation in the kind of patients we see, and other things are not well known, and we have to have a conversation about that. So one of the things we looked at was, within our hospital medicine group, was fragmentation of care and how that affects length of stay. And so David Tong, one of my partners, actually did analysis of billing data and computed a fragmentation of care index for our sites. So Emory, Midtown, St. Joseph's, Johns Creek. And what they found was that the fragmentation of care index was substantially higher than what we see in community-based settings. So on average, closer to 0.5. And if for one site we were actually able to look at the correlation between length of stay index and fragmentation of care, and that's at Midtown. And you can see there on the graph at the right, there's a very nice correlation between those two things. So as fragmentation of care goes up, length of stay goes up. As fragmentation of care goes down, length of stay goes down. Again, it's hard to know exactly which direction this mechanism is going, but it's certainly nice to, or it makes sense to believe that increases in fragmentation of care might negatively affect length of stay. Now, I want to spend most of the rest of the talk talking about healthcare delivery interventions to reduce length of stay. So this is kind of the meat of the talk because it's what we can actually do potentially to make things better. And so what some of our colleagues did was a systematic review of healthcare delivery interventions to reduce length of stay. And we asked 2 key questions here. The first is for adult hospitalized patients, what healthcare delivery interventions, so not medical intervention, not therapeutic interventions, not diagnostic interventions, but interventions that have to do with the delivery or structure of healthcare, what interventions can actually reduce length of stay? And then how do those interventions actually compare in terms of their effectiveness as well as a safety profile, so adverse events, readmissions, that sort of thing. And so we included articles were eligible, again, if they presented results from a controlled healthcare delivery intervention that was intended to reduce length of stay among hospitalized patients. And we included randomized controlled trials, as well as any prospective or retrospective observational studies, as long as there was a concurrent control. And we included data for patients hospitalized between the years 1990 to 2013. And the reason we chose 1990 was simply that there had been a number of changes in the healthcare delivery system over that period of time. And so we thought it would be hard to compare what would happen before 1990. We've also seen, as we showed, a substantial reduction in length of stay over that period of time. And so we thought this was a nice, potentially meaningful sample of a time period. We excluded trials that included pediatric patients, that included psychiatric patients or patients with critical illness. And again, we thought in obstetric patients, we thought those were slightly different populations where the results might not be generalizable to a general medical population. And we looked at the length of stay as well as some indicators of adverse events, so things like 30-day mortality. And importantly, we limited our study selection to US-based hospitals. And again, this has to do with differences in healthcare financing as well as the baseline length of stay, depending on where you are. So here's our study flowchart, and we're mostly through this at this point. But our initial search pulled up a combination of about 4,600 articles. After reviewing hand-searching records, additional records, we found another 141. And if you take away the duplicates, you ended up with 4,448 articles. And what we had was a couple of research assistants who reviewed these from the basis of title and abstract. And so 2 research assistants reviewed each of these articles. And that led us to about 4,131 articles that were excluded. And so the remainder of the articles, the other 297 articles, were reviewed by 2 physicians, and they reviewed the full text of these articles. And we made a decision on the basis of that whether to include them in the study or whether to exclude them. And you can see here in terms of right now we're about 215 articles that have been reviewed. The kappa, for those of you who are interested, is quite good. It's about 0.7. But for the ones that we're excluding, we made a slight modification of the protocol after the fact, which was that because of the volume of studies we were looking at, we chose to only include studies with concurrent controls. So previously we'd said that if you had a pre-post study and the pre was the control, that was probably not going to be good enough. We wanted some sort of concurrent control. And so when you did all this, we essentially had 28 studies that we were including in some sort of qualitative synthesis. So here's a chart just showing some of the study characteristics. And again, we grouped these studies into two big buckets. One are randomized controlled trials, and the second are controlled clinical trials. Those are quasi-experimental and cohort studies. And you can see here that there are 18 randomized controlled trials that we chose to include. And the median sample size was 280 in the intervention arm and 281 in the control arm. And we used something called something from Cochrane called the Effective Practice of Care Risk of Bias Tool to systematically assess the quality of these studies. And so that instrument includes 9 criteria, so that the total maximum score is 9. And they're looking at things like whether or not the study is using random and concealed allocation, whether they're documenting similar baseline characteristics. And you can see here that when you apply the EPOC score, the criteria, you do see some limitations in the quality of these studies. So the EPOC score was about 5. And you can see here that the median length of stay reduction across all studies was 0.5, but that there were only statistically significant results in 8 of the 18 studies, and among those studies, the reduction was actually 0.6 days. And here's what it looks like for the controlled clinical trials. So you can see here we have 10 controlled clinical trials that we included. The median sample size is 244 in the intervention group, 544 in the control group. The EPOC score here is a little bit lower, as you might expect. It's 4. And you can see here the average reduction length of stay is 0.69 days. And again, the only 6 of these studies actually demonstrated statistically significant results. And in those studies, the length of stay reduction was actually 0.69. The next step was to actually put this together in some sort of taxonomy of interventions. And what we thought was kind of a nice way to describe these are things that happened before the hospitalization, during the hospitalization, and after the hospitalization. And you can imagine deploying interventions in any one of these periods of time to actually reduce length of stay. And we'll talk more about some of these in a moment. So in terms of pre-hospitalization, we're looking at things like hospital at home, outpatient medical evaluation, especially before surgeries, strategies to increase patient engagement. During the hospitalization, we're talking about things like specialized units, patient engagement, decision support tools for both patients and providers, use of clinical pathways, and there are a number of studies looking at clinical pathways for everything from pain all the way down to various clinical conditions. Use of care coordinators, so these are people embedded in the provider team that essentially facilitate some of the care coordination, and then case management, discharge planning. And then post-hospitalization, you're talking about things like hospital at home again and transitional care. And so I want to talk a little bit about some of the studies that I thought were particularly interesting and maybe worth exploring here at Emory, or that may be worth having a larger conversation about. So one of my favorite studies is something called Hospital at Home. And this was pioneered up at Johns Hopkins. And the results were one of the first studies was published back in 2005 in Annals. And it's kind of a revolutionary concept to think about it, but essentially what they did was they took patients who came into the ER and had one of a couple of different conditions, cellulitis, pneumonia, COPD, heart failure. And what they did was on the basis of risk, they would essentially assign these patients to either a hospital at home program or they would admit the person to the hospital. And if you were in the hospital at home program, what they did was they actually sent you home with a nurse. That nurse would stay with you, or a nurse would stay with you for some period of time until you were stabilized. The doctor would come see you every day in the hospital. And then over time, as you got better, the nurse would reduce the amount of time spent in the hospital, the doctor would reduce the amount of time they came and visited you, and eventually you were discharged from this program. And what they found in this study was that about 29 to 69% of the patients, depending on the site, who were offered this intervention actually accepted it, which is surprisingly high. You can imagine it's a little bit nerve-wracking to think that you're sick and they want to send the doctor wants to send you back home. But that's roughly 50% of the patients said, yeah, that's not a bad thing. And then if you look at length of stay, the hospital length of stay versus the hospital home length of stay, it's actually a little bit lower for the hospital at home program. So 3.2 days versus 4.9. And the costs were actually lower for the hospital at home program versus the traditional hospital program. And as as I think about this, I mean, to me, this kind of strikes me as kind of a disruptive innovation, right? I mean, this was one of the first cell phones. Came out in 1973. It was called the Brick. It cost weighed 2.2 pounds, 4,000. And at the time, if you asked people, well, will everyone in this room now have a cell phone, which I imagine most of you do, people would say probably not. And it turns out that the cell phone had one competitive advantage, which was that it offered mobility. It offered freedom. That was the only thing it did well. But over time, it began to compete with on the basis of other attributes as well, and now it's something that we all carry around. And so you can imagine hospital at home may be something similar. It's probably only good enough for a very small number of patients who are extremely low risk, but you can imagine over time that our capabilities get better and better, and at some point, a large percent of our patients are perhaps getting cared for in that kind of setting. The next category of studies that we saw had to do with clinical pathways. And again, there were a number of studies looking at clinical pathways across a range of conditions. Pneumonia, it turns out, tends to be one of the more popular ones. It has to do with sort of the timing of transition from oral to IV, or IV to oral antibiotics. But this was a study that was done at the University of Cincinnati, and they looked at the impact of a clinical pathway for bowel resection. And one of the things to know about these clinical pathway studies is they generally have kind of the same process, which is they assemble some sort of multidisciplinary team. The team comes together, they develop a multidisciplinary pathway that includes, in this case, everything from when do you remove the NG tube, when do you advance the diet, when do you get the patient up and moving, all these different things. And what they found was they compared patients essentially who were in the pathway to those who were not. And what they found is that over the study period, the patients who were in the pathway ended up having, through kind of a differences methodology, a reduction of 1.97 days in length of stay. And that the costs in the length of stay in the pathway group are not surprisingly a little bit lower. This was a study by Bob Wachter and his colleagues over at UCSF, and we have Bob Wachter to kind of thank probably for the hospitalist movement or curse, depending on who you are. But what they did in this initial study was something called an alternate day. They did a trial where they essentially assigned patients to two arms. One was kind of the traditional service, which at the time was managed by outpatient physicians. And so this is probably how a lot of us train, which is a community-based doctor would sort of round in the patient sometime during the day. And then they had something called a managed care service. And that's essentially the hospital medicine service. So you can imagine, I mean, these physicians are there 24/7. They're actually rounding with the team on a much more sustained basis. And again, they looked at the difference between the traditional service, the managed care service, and what they found over the study period was there was a reduction about a little more than a day, about 0.6 days between the two services, and that the costs in the managed care service were a little bit lower than the traditional service. And this was one of the first studies looking at efficiency in hospital medicine, and sort of launched what we have today. The next category of studies we saw had to do with surgical co-management. This is another study by Leonore Huddleston over at UCSF, and they were looking at surgical co-management for orthopedic surgery patients. And if this looks a little bit familiar, it's basically what we do here at our orthopedic spine hospital. So essentially, you have a group of patients who are identified on the basis of risk, and depending on that risk, they are assigned to either a medical co-management with a hospitalist, or they are just seen by the surgeons. And in this case, they had 526 patients who were part of this study. And patients this is a kind of a pre-post study with a concurrent control. And what they found is that patients in the intervention arm actually didn't have any reduction in length of stay, but that when you looked at complications, there was a slight reduction in the kinds of complications that patients had. Now, generally, these were kind of minor complications, so things like electrolyte abnormalities, UTI, those sorts of things, but not a huge difference in terms of length of stay. When they did adjust for something called barriers to discharge, and there was a modest reduction at that point, although I think it's sort of a questionable thing to adjust for. But that's essentially what we do here. And one thing that's interesting to note is that despite the fact that there was no reductions in length of stay, despite the fact that the reduction in complications was subtle, all the providers, when you surveyed them, the nurses, the physicians, everyone felt like the quality of care being delivered to these patients was substantially better. The other category of study that we saw have to do with elderly patients and specialized units for them. And there are two things here. One is called acute care for the elderly, and the second, mobile acute care for the elderly. And so we found 5 studies looking at acute care for the elderly. 4 of these were randomized controlled trials. 1 was a controlled clinical trial. And these occurred in a range of settings from academic medical centers to community-based hospitals. And essentially what these authors recognize is that our elderly patients experience substantial functional declines during the hospitalization. And so they asked, if we develop a kind of unit that is specially targeting them with very specific protocols for mobility, for medication management, can we actually improve their outcomes? And what they found was a length of stay reduction in about 3 of these studies. And they also found pretty substantial improvements in their ability to perform ADLs and the likelihood of being discharged home. And interestingly, they also found fewer readmissions in those patients. Now you can imagine it's challenging. It can be challenging to start a geographic unit for just elderly patients, just from a resource perspective and a logistical perspective. And so a group of Mount Sinai said, well, what if you had a mobile service? So this is a mobile team, a team that goes from floor to floor to floor. It's comprised of a nurse, a geriatrician, nurse practitioner, and we'll have them focus on all the geriatric patients and provide a set of services that is probably very similar to what you might find on a specialized unit. And so they published a study in Archives or JAMA Internal Medicine just recently, and they looked at 173 patients who were matched through a cohort study. And what they found was a reduction in adverse events in the MACE unit, as well as a reduction in length of stay and costs in the MACE unit. The other category that we see has to do with mobility. So one of the things you'll know about patients in the hospital is that oftentimes they are in bed, not as active as they can or should be. And so there have been a number of studies looking at what happens when you enroll these patients in systematic efforts to improve mobility, do exercise. And so we found 2 studies that met that criteria. One was a randomized controlled trial, the other was a controlled clinical trial. And essentially both these studies are looking at elderly patients, so generally over the age of 60. They had to have some minimum length of stay, so generally more than 3 days. And they're excluding patients who are non-ambulatory baseline. So if you came into the hospital not being able to walk, then those are patients you're not going to put in the trial. So in one of the studies, they had a physical therapist actually screen the patient, and depending on the presence of skilled versus unskilled needs, assign them to a physical therapist or a PT aide. And the PT aide basically just got the patient up and moved them around. In another study, there was just a mobility protocol that was actually nurse-driven. So the nurses would take a look at they would see the patient, there would be a protocol for getting the patient up, and over the course of the day, they're actually expected to get the patient up several times. And what they found was, in one study, was no reduction in length of stay. In the other study, the controlled clinical trial, you saw a pretty substantial reduction in length of stay of 3.76 days, and a nice reduction in functional status in actually both studies. Another category study has to do with discharge planning and case management, and kind of the person that started this, a woman named Dr. Naylor up at Penn, and so Elizabeth Naylor, I believe. And so here we found 6 studies looking at early discharge planning and case management. 4 of these are randomized controlled trials. 1 of these is controlled. 2 of these are controlled clinical trials. And essentially, all these studies have sort of the same process, which is you identify a patient very early in the hospitalization, you develop some sort of individualized care plan, and then you provide ongoing patient and family education, and then you follow up both in the hospital and outside of the hospital, either via telephone or in-person visits. And those visits are, it can range anywhere from 2 to 12 weeks. And I think what's interesting to note here is there was actually no reduction in length of stay in a majority of these patients or studies. But what you do find is that a substantial reduction in the likelihood of being readmitted. So there may be other reasons to deploy some of these interventions outside of efficiency. There may be improvements in quality. In addition, you find fewer inpatient, outpatient costs in the patients enrolled in these case management discharge planning studies. Another thing that we found were interdisciplinary rounds. So this is, an example is that we've sort of put on steroids is here at Emory and at Midtown, which are cyber rounds. But this was a study that was done in medical care, published in Medical Care back in 1998. And essentially what they had were multidisciplinary rounds that included both a social worker, a physician, the nursing staff, nutrition, respiratory therapy. And what they found was that the length of stay in the interdisciplinary rounds group was lower, and that total charges were also lower. So some evidence says as you begin to increase multidisciplinary communication among the care team, you can also improve the efficiency of care. And the last study I'll tell you about, and this kind of reflects my interest in IT, have to do with decision support. And one of these is not an IT intervention, and one of these is. So one was at a community-based hospital, and essentially what they had were patients who were receiving IV antibiotics for pneumonia. And essentially what they did was some version of kind of academic detailing, kind of what Melissa Stevens presented just recently in our Department of Medicine Research Day. Except here they actually had nurses who approached patients, or physicians, where they thought there might be some opportunity to make that transition from IV to oral antibiotics. They did it in a very non-judgmental, very kind of friendly way. And they looked at, what was the difference in length of stay. And what they found was there was a substantial reduction in length of stay in those patients. There was another study from Columbia where they embedded some decision support into their IT systems. And here, they did this, it was a randomized control trial. They embedded decision support into patients admitted to neurology and general medicine. And the only thing they did here was put an expected length of stay. So at the bottom of the primary, electronic medical record was something that showed exactly what the expected length of stay for this patient ought to be based on the principal diagnosis. And the doctor could click on a button, and if they could get a sort of a deep dive into why we believe the length of stay was supposed to be that. And again, you see a reduction in length of stay of 0.24 days in a very large cohort of patients. So several thousand patients over the course of a year. So here, just in terms of summarizing what we're finding, we identified 11 categories of interventions. These range from pre-hospital to post-hospital. There are some limitations methodological limitations in these studies, but this is the best quality of evidence that we have. And that although fewer than half of these studies actually demonstrate a positive relationship between the intervention and length of stay, there are some that consistently show an improvement. So protocols and pathways, hospitalists, if you look at studies looking at hospitalists, repeatedly show a positive effect on length of stay. Specialized units for the elderly, and then decision support interventions seem to show some impact on length of stay. But we have to keep in mind that the efficacy of these interventions is probably going to be dependent on what's already in place. So you can imagine if you're kind of at the bottom of the curve, where your length of stay is a day, the marginal cost of actually making further improvements in length of stay may be increasingly challenging. So here are the take-home points. Hospital length of stay is measured in many ways. So it's important just ask what is being measured and know what's being measured. Length of stay is primarily a measure of efficiency, but at the same time, it can be a measure of quality, and it's increasingly being used in that way. There are substantial changes in reductions of length of stay are likely to expected to increase. There is no relationship between length of stay and readmissions as far as we can find, and that length of stay is affected by numerous factors, both the hospital level, the provider level, and the patient level. And there are several interventions that we can find that seem to reliably reduce length of stay, and there's a growing body of work investigating new interventions that may add to that body as well. And so with that, I'd be happy to take any questions.
Thank you very much. Excellent overview of length of stay. I was particularly interested in hospital at home. And can you elaborate a bit more? It looked like that the data on cost showed effectiveness of that kind of approach. Is this a Hopkins model, and can you comment a bit more on that approach?
Yeah, it is a Hopkins model. It was pioneered there. They've rolled it out a couple of their community-based affiliated hospitals at this point. We have versions of it even here at Emory. So, for example, we work with one of our providers in Quorum, and so if you're a patient with cellulitis, for example, and you show to the ED, it's considered a low risk, maybe just a failure of outpatient oral antibiotics. You can theoretically be sort of admitted to this program, and parenteral antibiotics can be started at home. Now, Jay Varkey's over here. I mean, I think there are a number of barriers you can imagine and that exist in this sort of model. But it's a growing area of interest, and I think a number of institutions are beginning to invest in those capabilities. And as we improve our abilities to monitor these patients remotely, I think you'll probably see an increase in their number as well. I mean, the other thing that's kind of driving all this and has been a limiting factor has just been reimbursement. Unfortunately, Medicare doesn't pay for hospital at home, right? It's something that comes out of the provider's pocket. And so as you move to a world of accountable care organizations and risk that we assume as providers, you can imagine the incentive to actually invest in these sorts of interventions goes up.
That was great. What is the impact of prior authorization on the length of stay? I was just trying to follow up.
So the
impact
question
of prior authorization on length of stay in the hospital, especially medications at the time of discharge.
Yeah, that's a great question. I mean, prior authorization is certainly something that is maddening, but I haven't seen anything looking at whether or not prior authorization increases length of stay. You can imagine there are certainly times where there are delays as a result of waiting for approval from the insurance company, and that happens quite frequently. I just haven't seen any systematic data looking at how often that happens. But I think you're absolutely right. I think there are instances where it makes a big difference.
Dan?
Hey, thanks, Arun. That was great. Even though I've seen this once before, I seem to learn something every time I see it. I guess one maybe simpler question around. We use you talked about some data on protocols and pathways and how we use these in the hospital, and those seem to be valuable and maybe for services that have a very narrow sets of populations. Seems like, let's always get to this order set, get to that order set. For those of us who see 50 different things in 50 different days, how do we get those when we do have conditions that have protocols? I know that different groups working on things related to COPD or coronary disease or heart failure. How do we get those immediately in front of the clinicians so we're using some of the things that will help us improve those or potentially help improve length of stay or other outcomes? And then the other quick question around kind of hospitalists and the data out there that shows improved length of stay. There tends to be also information around, kind of coming from the CEO, what have you done for me lately? I've seen that you improved length of stay for the first year or 2 years, 3 years, but hey, your length of stay now seems to be leveled off, and what can you do for me now, and how do we approach that kind of those kind of things?
Sure, those are great questions. So in terms of care pathways, I think these are primarily, the studies that I've seen have shown them primarily for high volume conditions. And they tend to seem to be most effective for elective admissions, as you suggested. So, for example, you're coming in for a knee replacement. It's fairly clear what needs to happen on day 1, day 2, day 3. It can be fairly prescriptive as well as predictive. It is certainly harder for medical conditions where we see a lot of variability. So the question is, but that said, there are patients who we see in internal medicine or general medicine where it is certainly the case that they could probably be engaged and enrolled in some sort of pathway, but are not. And so great examples of that are things like you mentioned, COPD, heart failure, pneumonia, I think is one where there's a real opportunity. And so you're right. Part of the challenge here is how do you develop processes that actually get these patients engaged on those pathways of care? How do you also develop enough buy-in from the entire multidisciplinary team to develop these protocols? And so I think the answer is at least in part to our electronic systems. So you can imagine when a patient, right now, when a patient's admitted, say, with pneumonia or heart failure, we may use kind of a very, very basic sort of order set. These are not really pathways. They're certainly not geared in a way or made useful, I think, to a lot of other members of the care team. And so I think there's an opportunity there to begin to make sure that those tools are available to everyone and that those things that we do are really reflective of a multidisciplinary pathway as opposed to just a couple of orders that we put in. And then the second question in terms of, what can we do now? I mean, I think it's important for physicians to be able to demonstrate value and articulate value. And so I think length of stay is one metric, and there may be other metrics as well. And I mean, you saw the curve. I mean, there's been a 30% reduction in length of stay since 1991. And you can imagine that there's probably still some opportunity, but at some point, it may become more and more challenging. And so I think it's just important for us to articulate exactly what we're able to do, be able to measure it, and be able to share it. There's some folks from administration here. Dr. Gartland's here. Certainly, if he has any comments, that would be instructive.
Doug?
What is your reaction to that? Primary heart disease, heart failure, coming out of Europe, that they say that the U.S. gets the patient out of the hospital quicker than they do in Europe. But if you go for a total year, the number of days in the hospital is the same. That is, there's fewer readmissions from the European patients, once they're in the hospital, staying longer. How do you react to that?
Maybe two things. I mean, one. Sure. So Dr. Morris asked, are my reaction to data from European studies looking at patients admitted with heart failure. And what they found in those European studies is that patients who are admitted with heart failure stay longer, but that over the course of the year, the number of days in the hospital is actually less than in the U.S. And so maybe two things. One is I haven't seen any relationship in international data or national data between length of stay and short-term readmission. I think certainly there is differences in our willingness to accept patients into the hospital, the decision to admit, and that's highly variable depending on where you are. So I understand that. I'm just not sure those two things are actually linked. In other words, just because you are discharged from the hospital earlier doesn't mean that you are likely to come back 3 months down the road, and that maybe but physiologically and just intuitively those two things are completely separated. There's certainly no relationship between length of stay and short-term readmission risk.
Bryce?
So I think this would be a great audience with a lot of the residents here talking about the fragmentation side of things, because I think it's applicable not just to primary services but our care system overall in terms of consultants and as well as primary services and even house staff rotations through. We've spent a tremendous amount of time focused in on safe handoffs, but a lot of this really begs to question, are we kind of misappropriating our time towards safe handoffs when really the challenge we should be facing is how do we reduce the fragmentation index overall and really kind of inserting into our overall care models. So interested in any insights into that.
Yeah, no, I think it's one of the surprising things that I found doing this, just the relationship between fragmentation of care and length of stay. And certainly there have been a number of environmental factors, system factors that sort of increase the number of handoffs. So I think in the absence of structural change that would limit kind of the natural fragmentation, I think our job is certainly to improve those handoffs as much as possible. But I think in our professional services, I think we see a lot of fragmentation depending on the service that you're in. And so I think that's up to us to begin to think about how do we begin to to reduce that. And it's going to require a lot of creative thinking in terms of how do you balance that versus our research requirements or administrative requirements and everything else. But at the end of the day, the question is, what is the actual impact of fragmentation on length of stay? And I think it's substantial. And I think there's also some evidence that fragmentation may reduce quality as well. So I think all these things are kind of tied together. And I don't have an easy answer for you. I think there are a lot of experts in the room. Certainly, if someone has an answer, I'd love to, or some insight, I'd love to hear it.
Dr. Johnson.
Great talk. Thanks so much. I had a question. Through your review, could you get a sense as to any of these interventions as to whether or not they might be scalable to the degree that we might want, or perhaps that some of the interventions might be combinable with other types of interventions?
I think a lot of these interventions are scalable. It's just what is missing is kind of a will. So you can imagine, take the one that Dr. Stevens talked about, the hospital at home program. There's nothing about it that is not scalable. I mean, you can imagine protocols that are developed, techniques for monitoring patients at home. All these things are scalable. What's been missing, at least for that, has been sort of the business model, right? Similarly, pathways, things like that are absolutely scalable. I think, we do a bad job, unfortunately, of reinventing the wheel in healthcare oftentimes. So there are, certainly, as you look at other hospital systems, it'd be great to begin to take protocols that have been developed and actually apply them here. But I actually think, a lot of these things are absolutely scalable. There's nothing intrinsic about them that makes them small.
Thank you very much. That was an excellent.
Thank you.
Always.